Good morning, everyone, and welcome to Cardiology Grand Rounds. So I have the privilege today of introducing Dr. Douglas Leedy. So as you know, he completed his residency here before staying on his fellowship. I have the privilege to say that I've known Doug for at least 6 years. I still remember when he was a resident and he approached me to work with me at the time asking about projects, and I told him, hey, we have some stuff in cardio-oncology. So this was about 6 years ago when most people didn't know what cardio-oncology was. Surprisingly, I was impressed by the fact he wanted to tackle this field. So he took on the projects and he really hit the ground running and has done really well in the field and is now known nationally for his work in the field. I'm also honored to say he's staying on after he completes this year as one of the general cardiology faculty, and he'll be working closely with the cardio-oncology program. So some background, as you know, he really excelled throughout residency and served as a chief resident before staying with us for his fellowship. He's known particularly as an amazing educator, the way he's able to break down and present information and showcase this throughout his chief year as well as doing his cardiology fellowship. Because of his ability to educate, he was recently elected to serve on a planning committee for the Washington State ACC annual meeting. He has published extensively in cardio-oncology with 14 publications during a training and is board certified by the International Cardio-Oncology Society. I'm constantly impressed by his skills in transferring information in cardio-oncology, and you'll have the chance to witness this firsthand today with a skillful breakdown of the recent cardio-oncology guidelines. Please join me in welcoming Dr. Leedy.
Well, thank you, Richard, for that kind introduction. And welcome everyone to Grand Rounds and those joining by Zoom as well. So as Richard mentioned, I'll be talking about the cardio-oncology guidelines. And I have no relevant disclosures for this talk. My objectives today are to give you some historical perspective on the field of cardio-oncology leading up to the 2002, the most recent cardio-oncology guidelines. Then we'll spend some time talking about those recommendations and then spend some more time about the limitations or maybe some of the areas of controversy within those guidelines. And then we'll conclude by talking about some of the future endeavors to improve upon those guidelines. So how did we get here? Well, let's go back to 1929. The roaring 20s have ended. The stock market has crashed. And Maddock and Thibodeau released the histologic findings of the effects of radiation on the heart. And they say it would seem that radiation on the human heart and its immediate vicinity may cause definitive injury to the heart muscle. It won't be for decades later that we come to fully appreciate the effects of radiation from pericardial and valvular disease, accelerated atherosclerosis, as well as heart failure. Typically, this having an onset many decades after the fact. Fast forwarding to the 1960s, there becomes case series and reports of cardiotoxicity as it relates to anthracycline use, or doxorubicin, formerly termed adriamycin. And again, decades later, we come to appreciate the effects on topoisomerase II and the detrimental effects on mitochondrial function, reactive oxidative stress, and DNA repair mechanisms. And we see a cumulative dose response with anthracyclines with the incidence of heart failure, where 250 milligrams per body surface area really is the inflection point for increasing cardiac dysfunction. And then moving to the 1990s, the World Wide Web is now a thing, and the FDA approves HER2 therapy for breast cancer, with Herceptin or trastuzumab being one of the first ones. And within the randomized trials, in patients who are overall low cardiovascular risk, we see patients have about a 5 to 10% incidence of cardiac dysfunction. Double that if they're on concurrent use of anthracyclines. And when we look at the non-randomized settings where patients are perhaps at an increased cardiovascular risk, we see much higher rates of cardiac dysfunction related to that cancer therapy, especially when it's concurrently used with anthracyclines. It was because of studies like this that we now have moved away from concurrent use of anthracyclines with HER2 therapy. And if we need, we do sequential anthracyclines followed by HER2 therapy. And then now entering the early 2000s. Now this is the era of targeted therapy, also the last decade where I had a full head of hair. And we see Gleevec or imatinib really set the stage for kinase inhibition. This was in the treatment of CML. And then following that, we see really an explosion of different kinase inhibitors for different types of cancers. But we also come to appreciate off-target effects of kinase inhibition, where I think it's pretty well known the VEGF association with hypertension, but also many other ones like heart failure, venous thromboembolism, metabolic derangements, AFib, and the like. And then entering more contemporary times, where we see immunotherapy hit the stage. Immune checkpoint inhibitors have really taken off, and we've seen really exponential growth in the FDA indications for different cancers. But just like all those other therapies, we come to appreciate some other side effects in the form of immune-related adverse events, where myocarditis is really the most feared one, with some early reports suggesting up to 50% mortality. And then even more recent times within immunotherapy, T-cell therapy. I think many of us are familiar with CAR T-cell therapy or chimeric antigen receptor therapy, but even more recently is BiTE therapy and tumor infiltrating lymphocyte therapy. And the common denominator amongst all of these is cytokine release syndrome. This is mediated by interleukin-6, and it presents with hypertension, fever, and organ dysfunction, including cardiac dysfunction. And in the non-randomized settings, we see a high incidence of cardiovascular events, about 30%, and about a 10% cardiovascular-related mortality if patients have grade 2 or 3 cytokine release syndrome. And that's just a very brief overview in a historical perspective of some of the drug classes that have cardiotoxicity. There's many, many more. And because of that, that's really self-defined the role of the cardio-oncologist. From pre-cancer risk assessment, thinking about cardioprotective medications, and then during therapy, thinking about addressing pre-existing cardiovascular disease, detecting and managing the cardiotoxicities that ensue, and then long-term and survivorship, looking for late onset effects. And this is all within close collaboration with the referring hematologist oncologists. So where are we now? Well, presently, there's over 18 million patients in the US living with cancer. That's expected to grow up to 26 million by the year 2040. And to put that in perspective, back when we were first learning about the cardiotoxicity related to anthracyclines, we had less than 250,000 patients living with cancer. So presently, we have more patients living with cancer and also more patients at risk of developing cardiotoxicity. And in some cancers, we're seeing increase in incidence, unfortunately, breast cancer, for example. But fortunately, thanks to improving cancer therapeutics, we're seeing declining cancer-related mortality. So much so that we're seeing cardiovascular disease become the #1 cause of death, especially in cancer survivors. For example, in breast cancer survivors, they have increased mortality related to cardiovascular disease compared to patients who don't have breast cancer. And the same paradigm can be said about childhood cancer survivors, where they experience a 20% decreased survival at 30 years compared to age-matched cohorts. And that's primarily related to non-cancer related death and cardiovascular disease being #1. So because we're having increasing prevalence of cancer, patients are living longer thanks to improving cancer therapy. Cardiovascular disease has really been the focus in the last decade, and that's where cardio-oncology has really taken off, both in research and also different iterations of guidelines. So starting off in 2014, the American Society of Echocardiography and its European counterpart released some guidance for us. And this was primarily related to the effects of anthracyclines and HER2 therapy. Then 2 years later, our Canadian and European counterparts released position statements kind of similar scope. And then a year later, the American Society of Clinical Oncology also released their own guidelines. This was, again, primarily focused on HER2 therapy and anthracyclines as it relates to breast cancer. And then a couple of years later, the European Society of Medical Oncology released their guidelines. And these are a little bit wider in scope, thinking about the individual risk of the patient when you think about cancer-related surveillance. But at this point in time, we really didn't have one guideline to refer to. None of these harmonized all those prior guidelines, and none of these really encapsulated all the major topics that we address within cardio-oncology. It was with that that we had great anticipation for the 2022 ESC Cardio-Oncology guidelines. And this was a massive undertaking and really a first of its kind that really encapsulated and covered every major topic within the field. It involves 30 different international experts from 13 different countries. And it's a massive document, over 130 pages, so nearly a book or a novel. And they have a figure or table for just about anything, over 120 different figures and tables, nearly 1,000 references, and then 272 different recommendations. And to put that in perspective, the average ACC AHA is 121, so more than double the amount of recommendations. So just highlighting how much coverage these guidelines cover. And as I mentioned, there's a table or figure for just about anything, and just about any different drug class that's associated with toxicity, they have one for you. So it's a great reference to refer to. And it's also multidisciplinary in that it covers topics, within EP, like cardiac devices as it relates to radiation, different protocols on how to handle that. There's even a section on cardio-oncology within cardio-obstetrics. So a little bit of something for everyone. And this is the first guideline to really focus on a risk-tailored approach, from baseline risk to during therapy and then long-term survivorship, where you think about the pre-existing modifiable risk factors before starting. You think about surveillance based on the patient's risk during therapy and their risk thereafter. And they're really focused on that baseline risk assessment before starting therapy. We think, again, about pre-existing cardiovascular disease, modifiable risk factors, perhaps their previous cardiotoxic therapies they received, and then taking that and thinking about their intended cancer therapeutic moving forward and what the risk associated with their pre-existing disease is. And then based on that, the guidelines give you recommendations for screening, like based on echo, cardiac biomarkers. And the ESC gives us class of recommendations and level of evidence that we're all familiar with from the ACC/AHA guidelines, where class 1 is indicated, recommended, class 2A should be considered, and level of evidence A, multiple randomized trials, B being maybe a single randomized trial, and C primarily being expert opinion or retrospective studies. So bear with me, I want to cover all the class 1 level A recommendations. There's only 5. And the first 2 are pretty straightforward. They have to deal with with VTE. And they say that edoxaban, apixaban, rivaroxaban, as long as the platelets are greater than 50,000 low molecular weight, heparin should be used in the management of VTE. Pretty straightforward. The next one relates to prophylactic use of low molecular weight heparin in patients who are at high risk for VTE while being treated during the first 6 months of multiple myeloma therapy. Number 4 is patients who are on ribociclib should have QT monitoring, baseline 14 and 28 days. And then finally, cardiac MRI is recommended in the evaluations of patients suspected of having light chain associated cardiac amyloidosis. Now, I'll spare you the remaining 267 recommendations. And instead, what I want to do is pivot to some of the areas of controversy or limitations. And the reason for that is not to take anything away from these guidelines. And I think if you ask Drs. Otto or Stout, they'll tell you that trying to get experts in the same room at the same time, let alone on anything, is nearly impossible. And no guideline is without its limitations. And I think for a lot of us, we're not as familiar with the cardio-oncology guidelines or the evidence that supports it. And probably most importantly is if we can identify the areas of limitations, we know how to improve for future iterations of guidelines. So within these guidelines, one area of controversy is that they're very, very divergent from current clinical practice within cardio-oncology at most centers. And that's primarily because a lot of the recommendations are low quality, level C, and primarily expert opinion. And also the current infrastructure, such as the ease of access to advanced imaging. There's many recommendations for cardiac MRI, cardiac CT, 3D echoes, brain. It might not be applicable to all healthcare settings. And also the amount of referral centers for cardio-oncology is lacking as well. And then finally, the guidelines are very resource intensive as it relates to surveillance. It may not be adoptable in more resource constrained regions. So let's take a look at the quality of evidence that support the current guidelines. As this table depicts, a majority, 3/4 of all recommendations are level C evidence, primarily expert opinion. When you focus on just the class 1 recommendations, only 3% of the class 1 recommendations are supported by level of evidence A. And a majority, again, 3/4 are supported by level of evidence C. But how does that compare, at least the class 1 recommendations, to other guidelines? So if you look at a 10-year period within the ACC, AHA recommendations, they're supported by more robust evidence. Nearly 15% are level of evidence A, and a majority are level of evidence B. But the field of cardio-oncology is young, mature, and growing. And it's very difficult to do large multi-center randomized trials. So maybe a better comparison is adult general heart disease guidelines, where it's also difficult to do multiple and large randomized trials. They similarly have a fairly low level of evidence A to support the recommendations, but still have a majority level of evidence B. But Rome wasn't built in a day, and let me read you this quote. Information base from which to make clinical management decisions has greatly expanded in recent years. Yet in many situations, management issues remain controversial or uncertain. Unlike many other forms of cardiovascular disease, there is a scarcity of large-scale, multi-center trials addressing the diagnosis and treatment of patients with blank disease, from which to derive definitive conclusions. Can anyone guess where this is from? This was from the first iteration, what now, 25 years ago, the Valor guidelines. But I think if this is any benchmark for where the field is going within cardio-oncology, I think the future is bright and something to look forward to. So another area of controversy is that there's a lot of job security for us. There's a cardiology referral for many. So there's class 1 recommendations for anyone who has pre-existing cardiovascular disease, anyone who has abnormalities on the baseline risk assessment, anyone who develops new cardiac symptoms or abnormalities on screening both during and after. And then finally, there's class 1 recommendations for anyone who's deemed high or very high risk during that baseline assessment. And to give you an idea of what that looks like, if your intended therapy is a VEGF inhibitor and you're older than 75 years old, or if you have a history of hypertension, you're high risk and you have a class 1 recommendation to see a cardiologist. But what do the guidelines say when they say cardiology referral? Well, they say that they should refer to a cardio-oncology program or a cardiologist with expertise in managing cardiovascular disease in patients with cancer. Let's dig into that a little bit. So presently there's 36 centers of excellence, actually 37 now. I think UPIT just got added on as of yesterday. And these are defined by the International Cardio-Oncology Society. And if you zoom in on the western half of the United States, everything west of Mississippi, there's only 4 centers of excellence. Now, that's not to say that there's not great cardio-oncology programs, say at UCSF or Denver, or cardiologists with those expertise out in the community. But just highlighting that there's probably a lack of referral centers and access for these patients if we were to adhere to the guidelines as stated. So overall, there's a lack of that critical infrastructure from the referral centers, but also our current workforce as well. You know, currently there's only 10 in the US fellowship sites, taking typically 1 fellow a year. And there's no ACGME guidance on providing cardio-oncology dedicated training within general fellowship. And then probably most importantly, few cardiologists and oncologists feel comfortable taking care of these patients. And another area of controversy surrounds surveillance. Here is the guidance provided within the ESC guideline for monitoring HER2 therapy, trastuzumab, Herceptin, and the like. And the ESC adopted the FDA recommendation of echo every 3 months, whether or not you're low risk or high risk, because that's what they used in the seminal trials back in the 90s. What that looks like is 6 to 7 different echocardiograms, 7 blood draws for biomarkers, and an EKG. And there's over 50,000 patients yearly who are eligible for HER2 therapy. So if you do quick math, that's over 250,000 echocardiograms just directed for HER2 therapy a year. The same could be said about the screening for anthracyclines. If you're high risk or very high risk, that's 6 echocardiograms, 9 blood draws, and the EKG, just for cardiac surveillance. And unlike HER2 therapy, anthracyclines are used for many other different types of cancer, from leukemia, lymphoma, breast cancer, sarcoma, among others. So a lot of different patients could be at risk and would need this level of surveillance. And what gets confusing is I had highlighted that there have been several different iterations of the guidelines, and all of them are just a little bit different in their recommendations. For example, ASCO gives recommendations for monitoring HER2 therapy, and they say that if you're low or high risk, you just need a baseline echocardiogram, and only if you're a high risk, they leave it up to the clinician to decide how aggressively that patient should be screened. And what about immune checkpoint inhibitor therapy? As I mentioned, there's exponential increase in FDA indications, and so much so that greater than 1 out of 3 patients are eligible for ICI therapy. And this is what the ESC guidelines recommend. They give class 1 recommendations for baseline echo and troponin, and then throughout therapy should be considered class 2A, monitoring for troponins. But unlike in HER2 therapy or anthracycline therapy, where we really don't have evidence to suggest that we need more or less screening, we do have some randomized trials within ICI therapy. And that comes by way, or only one large randomized trial looking at this is the Javelin Renal 101 trial. This is where they took nearly 1,000 patients with renal cell carcinoma and randomized them to a tyrosine kinase inhibitor versus a tyrosine kinase inhibitor plus immune checkpoint inhibitor. And they prospectively screened these patients with serial EKGs, echoes, biomarkers, and had MACE essentially adjudicated. Importantly, before even starting treatment, patients had a high level of baseline elevated troponin, 20%, just highlighting how non-specific troponin can be, especially in a population that probably has underlying renal dysfunction, where 80% of these patients had a prior nephrectomy. So what did the Javelin trial show us? Well, overall, myocarditis is rare, less than 1%. And if you use the Lake-Louise criteria for defining myocarditis, only 2 patients met that. And 1 out of 2 of those patients had an elevated troponin. So the authors concluded that baseline and surveillance monitoring for troponin is not helpful in the identification of myocarditis. And we see similar results in single center experiences. This one out of Sloan Kettering, where they have 76 patients with metastatic melanoma treated with dual immune checkpoint inhibitors, so elevated risk for myocarditis. They saw no evidence of myocarditis, cardiovascular events, elevated troponin, nor abnormalities on EKG. And then finally, the Stanford experience. We had patients on single or dual immune checkpoint inhibitors, over 200 of them, and they were similarly prospectively screened with troponin. They saw elevated troponin in just over 1 in 10 patients and a fairly low rate of myocarditis, it's over 1%, and a fairly abysmal positive predictive value of 12.5%. What was important about this study is that they also highlighted the downstream effects of monitoring for troponin, where 14% were referred to the emergency department, over half referred to cardiology, probably most importantly, 14% had interruption in their cancer therapy while further investigating these elevated troponins. But Doug, so you may say, Doug, these are just guidelines. They provide, recommendations, guidance. They're not law of the land. But I think a lot of us feel external pressure to follow guidelines, especially class 1 recommendations. And especially when we have initiatives like the Get With the Guidelines campaign. So it makes you wonder, will adherence to these guidelines be tied to performance metrics, educational funding in general, and will insurers reimburse for all this advanced imaging and all this cardiac surveillance? And are there medical legal implications of this? Previous guidelines have been used in the court of law for malpractice cases. And I think probably even more importantly, will disparities be created or widened in resource-constrained regions that have trouble adhering to this very resource-intensive screening? So again, I highlight those limitations, not to take anything away from the current guidelines. Every guideline is going to have those similar limitations. But I want to use this as a springboard for where do we go from here? How do we improve upon this for future guidelines? And I kind of summarized the limitations into kind of 3 buckets: limited evidence, lack of infrastructure, and very resource-intensive screening. So where do we go from here? Well, bottom line, we need better data. And that'll come by the way of randomized trials. And that's historically been difficult because patients with active or advanced cancer have been excluded from our cardiology trials, and vice versa. Patients with advanced or pre-existing cardiovascular disease were excluded from the oncology trials. So we need to make investments into collaborative research where we have cancer and cardiovascular disease as hard outcomes. We better appreciate the true cardiotoxicity, what that incidence looks like. And if we can better understand that, we can better understand who's at risk, refine our risk models. If our risk models are improved, we can better adapt our screening strategy to target those at risk. This will also allow us to assess the effectiveness of preventative and secondary treatment of cardiotoxicity. And I think hope is on the way. Back in 2013, the National Heart and Lung and Blood Institute convened a workshop to try to harmonize all the definitions we were using at the time to define what cardiotoxicity meant. As an example, cancer therapy-related cardiotoxicity had very many different definitions at the time. Was it ejection drop of 10%, below 50% overall, or a GLS, global longitudinal strain, relative of 15%? So their job was to harmonize those in order to harmonize all the future research in the field. And then in 2016, a then much younger version of himself, and then Vice President Joe Biden releases the Cancer Moonshot Initiative. And this really invigorated interest and, more importantly, money into oncology research. And one of the big bullet points within the Cancer Moonshot Initiative was better understanding and treating the cardiotoxicity as it relates to cancer therapy. And then in 2018, that same workshop reconvenes, starts thinking about how do we do good randomized trials within the field of cardio-oncology. And as you can see, over this last decade, we've been seeing increase in funded projects from the NIH, also increased total funding for the field of cardio-oncology as it relates to research. But I think more is on the way to improve upon that data. So let's talk about the infrastructure for a second. So I think we can learn a lot from the UT Southwestern experience. And they just published this earlier this year. And during the COVID pandemic, they developed this novel service line with 3 goals in mind. One is to increase access, quality, and equity of cardio-oncology care. And they started off with a strategic vision where in an 8-hospital system, they got buy-in from everyone. And then they developed standards as it relates to their protocols. How early would a new referral need to be seen? How about for cardiac MRI, cardiac CT, echo, strain? our protocol is going to be for different cancer types and cancer therapeutics. They then surrounded that with a dedicated staff from the oncologist, cardio-oncologist, and the heart failure specialists and the like to support that clinic. And then they went out and promoted access to their clinic. They went out to the rural committees, to the clinics to promote access. And in doing so, just within 3 years of going online, they increased their new referrals 5-fold. And in doing so, rapidly expanded their regional coverage. They included a population of 2.4 million. And then more importantly, now had access to over nearly a 250,000 rural patients who previously didn't have access to cardio-oncology care. And then furthermore, this was a springboard for research for them. All their new referrals were put into a cardio-oncology registry. They were biobanked. And this allowed for multidisciplinary and collaborative research to ensue. So I think we can learn a lot from the UT Southwestern experience. And here at the University of Washington, we're also seeing an increased need for access. Just in the last 12 months, from February to February, we have 550 new referrals. And then lastly, let's talk about screening. And I think we need to think about screening from a value-based screening perspective, where more is not always better. And I think this goes beyond just cardio-oncology, but to cardiology and really medicine in general. When you think about screening and increasing intensity from the individual patient perspective, that's good. More screening, you pick up more disease. But with that, there's a healthcare cost to offer that. But there's also a harm from the patient level perspective too, from false positives, delays in cancer therapy. And those harms and costs are additive. So much so that the true value of screening declines at a certain point. And the optimal point is somewhere in the middle. Now, in 2014, spurred by increasing healthcare costs, the ACC-AHA released this document. And in this document, they proposed a cost-effectiveness analysis for all our future guideline recommendations. And they developed a level of value framework similar to the level of evidence we use within the guidelines. And value was defined as the dollar amount per quality adjusted life year gained. High value would be less than $50,000 per quality, and low value greater than $150,000 per quality adjusted life year gain. So going back to our framework with that in mind, if you have healthcare expenditure on the x-axis and patient outcomes or quality on the y-axis, we really want to be operating on the upslope of the curve, where increasing dollar of screening increases or improves patient outcomes. So right here, this is high value screening. And unfortunately, a lot of our screening that we do in medicine operates on the flat of the curve or low value, where increase in intensity or putting in more money does not necessarily correlate with improved patient outcomes. And this has been done before within the field of cardio-oncology. For example, determining the optimal echo screening for heart failure in patients who are childhood cancer survivors. Now, cost-effectiveness analyses are fairly complex and a little bit beyond me, but kind of in short, what they did was they did microsimulations of the risk of heart failure based on the childhood cancer study. And they used the performance echocardiography to detect these abnormalities, such as heart failure, incorporated the treatment effectiveness of heart failure, and included the cost to offer this screening. And then based on that, they were able to come up with an incremental cost effectiveness ratio or value for each risk category. And they define good value as less than 100,000 per quality. So if you were high risk, 2 years screening echocardiogram was high value. If you're moderate risk, every 5 years. And if you were low risk, no screening at all. So I think we can use these similar cost effectiveness analyses within all of our guidelines, including the ESC Cardio-Oncology guideline, to really think about, is this cost effectiveness from a system and a patient perspective? And I think it would also be helpful to think about a more risk-tailored approach. especially for HER2 therapy. As I mentioned, the ESC guidelines adopted the FDA kind of one-size-fits-all model. Whether or not you're low, intermediate, or high risk, doesn't matter. You'll be getting an echo every 3 months during therapy. But we've known for some time that if you have a history of hypertension, you have a baseline low EF, or a history of anthracycline use, you're at a greater risk. And in a study of nearly 1,000 patients, they retrospectively looked back to see who dropped their ejection fraction on those follow-up echocardiograms. And what they found was that if you dropped your ejection fraction by more than 5% on that first screening echocardiogram, you were very likely to go on to develop cardiac dysfunction related to HER2 therapy. But if you did not, you were very unlikely to ever develop cardiac dysfunction. So I think taking studies like this, we can better delineate who's at higher risk and offer treatment strategies towards that high risk group and away from patients that we know who are low risk. There is some hope on the way in the form of randomized trials. This one is currently enrolling, and they're looking at patients being treated with HER2 therapy who are low risk, and they're using a baseline 6-month, 12-month strategy compared to the standard of care, which is every 3 months. So I think we'll learn more after the study has completed. And then within our risk models, currently even within anthracycline therapy, we're very dichotomous, black and white. If you have pre-existing cardiovascular disease and are aged over 75, you are high risk. For that same patient who has some pre-existing cardiovascular disease who is 74 years old, you are lower intermediate risk. So I think studies like this highlight how we can do a better job at risk prediction, where they had 450 patients with leukemia treated with anthracyclines, and with multivariable regression analysis, we were able to come up with a 21-point and weighted risk score. And as you can see, that they were able to delineate very well high, intermediate, and low risk. And this wouldn't be a talk in 2023 in the era of ChatGPT without at least one slide on artificial intelligence. And I do think AI has opportunity and to improve the field of cardio-oncology. We've known for some time that machine learning and AI can make very reproducible assessments of LV function, from ejection fraction, then probably more importantly in our field, global longitudinal strain. As you might recall, just a couple percentage points on that GLS could be the difference between cardiac dysfunction related to cancer therapy versus normal. Now, machine learning can have nearly zero variability. Doesn't mean it's more accurate. Just means that it's less variable from study to study. And I think AI also may have a future role in risk prediction as well. This is a study of over 1,200 patients who are childhood cancer survivors at St. Jude who were continued to, after survivorship, to be followed with prospective screening with EKGs. And in some shape or form, AI was able to look at those EKGs and predict who was going to develop late onset cardiotoxicity as it related to the anthracyclines they received. And it performed a lot better than our traditional clinical models, which historically have been, have you received high-dose anthracyclines? Did you have a history of chest radiation? Did you smoke? Things like that. And I think there's also a role for integrating AI within our electronic medical record system. This one out of Cleveland took over 4,000 patients and used AI more or less to data mine the echo data, the lab data, and the other clinical characteristics to help them predict who is going to develop cardiovascular disease. And as you can see in the red line, heart failure, AI did a pretty good job at predicting who was going to develop heart failure. Less so for things like stroke or MI. But I do think AI is here to stay. And I think AI is probably better than some of the models we're using currently. For example, I asked Dolly, the ChatGPT image creator, to make me an image of cardio-oncology, cardioprotection. And they gave me this beautiful image of a heart seemingly being protected by cancer cells. I then inputted the same prompt into the Google search engine. And this is what I got. I think I see where they were going. Maybe exercise is cardioprotective from future lung cancer. I'm not sure. But again, I do think AI has its place. So I'll conclude by saying that the field of cardio-oncology has come a long, long way. From understanding of cardiotoxicity to the managing its effects as well. In the 2022 ESC Cardio-Oncology guidelines are a humongous document that's really all-encompassing and really provides a roadmap for future iterations of cardio-oncology guidelines. And I think ultimately to advance the cardiovascular care of the oncology patient and to improve upon future iterations of these guidelines, we'll need to make investments into randomized trials and also improve our infrastructure as well. And before I leave, I do want to say a special thank you to Richard Chang, my mentor over the last 5+ years. He's been a fantastic mentor. And really, like any great mentor, my success has been his success. So thank you, Richard. Also want to highlight Marta and Janie Sadlaw. They've also been a mentor to me, both in clinic and elsewhere. And I want to leave by saying how excited I am to join this great group of people this next year. So thank you.
So Doug, that was a wonderful overview of the guidelines, and I really like the way you conceptualized sort of all the key concepts here. I think there's, it's definitely an evolving field. We're very excited to have you join our group. I think this will be very exciting moving forward. I'm curious to see where there's any questions from the audience. Well, there's a lot, so go for it.
Yeah, that's always gets the first go.
Hey, Doug, thank you for a very good talk. I mean, just very well presented. The slides were very easy to look at, One question I have is kind of a two-part question. So as
you only get one.
As we're expanding access through access of cardio-oncology to more people, I want to know, how did UT Southwestern, exactly do that? And are they expanding it to people from lower resource backgrounds? And as we are expanding that access, the guidelines obviously need to be updated as we get more data. Mm-hmm. And which class 1 recommendations, or which are some of the most important recommendations you think might change? What direction do you think it might change based off of the data?
Yeah, to answer your first question, and that's why I highlighted that study from UT Southwestern, is because, as you point out, I think probably the most important takeaway is that now nearly 250,000 rural residents, perhaps underserved or at least resource constrained before, didn't have access to cardio-oncology care before they, rolled out that cardio-oncology service line. So just by dramatically expanding, their circle, their area of care, I think, they're now offered cardio-oncology care in those settings where previously, that was not available or not known. So I think what they did right was really get buy-in from, this is a huge system, 8 different hospitals, many, many different clinics. They also went outside their system, out in the community, and branded, and told those clinics, had big, advertising things of, we're here for you. And by doing that, you're able to expand coverage all around.
Yeah, so I also want to comment just locally within the state. So we were doing some work with MultiCare with, in terms of expanding access to cardio-oncology care throughout the state, including to, Southern Washington as well as Eastern Washington. I would say in the last several years, because of the large volume of referrals we've received locally, we haven't had as much ability to accommodate these patients. But I think with, people like Doug and Effie joining us, efforts will probably start again.
Can I just follow up on that question? Doug, this was an excellent TED Talk, probably the best I've ever seen. So on the flip side, how do you expand the workforce? I mean, you show that you go out there and you tell people to refer, you'll get more referrals, but
Yeah.
we're struggling with heart failure, general cardiology. I mean, is this going to be more fellowships? Should it be integrated into like core curriculum for general cardiology? What do you think about that?
Yeah, I think that's going to be probably the bottleneck is the workforce issue, not just so much the referral centers, but the workforce. I think we need to do a better job kind of at the ground level in terms of within fellowship, ACGME, perhaps releasing something that's more dedicated to general fellows. Because as I pointed out, there's not many dedicated cardio-oncology fellowships. And most of those are research scientists oriented. So that's going to have limited clinical availability. So I really think the only way to improve access is to improve the workforce first, from fellows, to nursing all across the board.
Doug, I think everybody's going the same line of questioning. I was wondering, maybe the best is to try to go after the low risk people and maybe get less screening, right? I think maybe that's the opportunity, because the people who are high risk, they'll have, they're sick, they'll come in, because I really like, can you comment on that? Because I think we're probably screening too many people. Don't you think so?
Yeah, and that's what I tried to highlight is what's challenging is like for HER2 therapy, we don't have evidence to suggest higher or lower. We just don't know yet. So like studies like the one I highlighted that's currently enrolling is doing just that, is trying to reduce screening in a low risk population.
Right. I guess any opportunities for us to do, I mean, Fred Hutch is huge. And I mean, why do we have to wait for other people?
Yeah.
I have a question about the sort of practicality of this risk stratification. I mean, clearly it can have an impact, as you showed, identifying people who didn't need screening, who benefit from it. Who does that, and what tools are available for that? That is identifying the low, medium, and high risk people right now.
Yeah, good question. So like that baseline risk assessment before therapy, who defined it as high, low risk?
Yeah.
Is that what you mean?
I don't need who did it for the studies.
Yeah,
Who's going to do that?
exactly. Yeah, absolutely.
The studies, they're dedicated to making finding that data and calculating those scores. But when that goes into the clinic, those people aren't available. So
Absolutely. Yeah. And that kind of goes back to Tomio's question too, is regarding the workforce. So almost all these patients will be deemed high risk by their referring oncologists. So we won't be seeing, for most of these, we won't be seeing these patients if they are low risk and not referred. But it starts with the oncologists are usually the referring provider. Sometimes in like long-term survivorship, that might be the primary care doctor as well. So by and large, most of these patients won't be seeing a cardio-oncologist. They'll be seeing an oncologist, they'll be seeing a primary care doctor. Some may see a cardiologist as well. But for the majority of them, they're not going to be seeing a cardio-oncologist. So that's why I think we need to do a better job, as Tomio was highlighting, of really educating the current workforce. But from a day-to-day thing, a lot of times that's the oncologist doing that in terms of deciding who's high risk.
From a systems of care perspective, there was a big push from the NIH Comprehensive Cancer Center model to integrate palliative care into comprehensive cancer centers. Do you see that as being the future for cardio-oncology, like, the designation of a comprehensive cancer center, including integrated cardio-oncology?
Yeah, I think that's a great question. I think within programs that have, they're all in-house from the oncologist to the cardiologist, I think palliative care naturally, is encapsulated within all of that. So I really do think that's like probably kind of the goal to look forward to, is having that, all-encompassing service line that includes palliative care.
Doug, can I ask one more? Because the people who are here should ask the more questions than the online people.
Yeah.
Just to follow up, so for coronary disease, we have heart team and all this stuff for the valve team. So do you guys have that kind of approach where you have multidiscipline meetings with the oncologists and stuff? Is that in the horizon? Is that happening now?
So from a day-to-day, it's a lot of phone call messaging, like after you see a patient get referred to you, just talking with the referring oncologist like that day. In terms of, research, there are, a lot of different groups that are collaborating. Richard, I don't know if you have anything more to add to that in terms of like a heart team approach.
Yeah, so I think that's a very valid question. I think it's something that we, have been working on closer with Fred Hutch. I think some centers have this. I would say in general, most centers, Cardio-Oncology is a program that integrates within HEMONC, but not necessarily in a heart team model, because there's a lot of heterogeneity on the HEMONC side of things also, right? Because within their field, for example, the stem cell transplant group is independent from the breast group. So it makes it a little bit harder to make a single cohesive heart team in that type of model. So I think it's more, we act as a central hub within cardiology to facilitate all of the care from all the different hematology oncology subspecialties, regardless of what discipline of cardiology it needs to be. So for example, we get some patients and just, help facilitate for TAVR, for interventions, to manage their heart failure, their arrhythmias, all sorts of things.
Right. I guess because the decision to halt therapy is so important, right? I guess that's the one that I think would be critical, right? Because that, as Doug showed, it's a big deal, right? To stop or delay. Maybe for something like that, it's important to make sure that all the stakeholders are discussing things with each other.
No, it's very true. I think that segues nicely to a question online from Jim Kirkpatrick here. So Jim says, fabulous talk. It strikes me that so much evidence is on cardiologists and screening, which with AI and clear pathways probably shouldn't be necessary. What about treatment? If the guidelines look at this as getting people through chemo and through treatments rather than identifying risk, we may be in better shape. So essentially he's asking, should our focus of the guidelines be how do we safely get patients through treatment, as Farida was alluding to?
Yeah, no, Dr. Kirkpatrick, that's a great question. Because as he's aware that, interruptions in cancer therapy can be devastating. There's this concept within cardio-oncology of permissive cardiotoxicity, where we allow someone's ejection fraction to be in the 40s. And we will provide cardioprotective medications, but our goal is to, at the very least, get them through therapy, their life-saving therapy, and really no matter the cost, to a certain point. So yeah, I think that is a different frame shift within guidelines. These guidelines are very diagnosis heavy, screening heavy, whereas right now treatment is limited. And it's primarily limited by limited evidence. We've been having ongoing trials, like STOP CA with statin therapies, preventative and things like that. But we're still not very robust in the level of evidence we have for management and treatment of cardiotoxicity. So to answer your question, I think hopefully in the near future, we'll have options and future guidance on the treatment of these cardiotoxicities.
Great. And there's another question here from Jeff Probsfield. Is there a simple algorithm for referring from internists and our cancer treating colleagues? Development of such an algorithm seems key.
Say that one more time.
Is there a simple algorithm for, I guess, when to refer for the internists and our oncology colleagues?
Yeah, one of the earlier slides I had. So the ESC has really nice figures and protocols in terms of when to refer. One of them being, looks like, where did that go? Here. So they have a whole, I think it's probably 5+ page section just on this. And within the text, they really detail what this cardiovascular risk assessment looks like. Even at baseline, during and after therapy, within long-term survivorship, of what is high risk, what is intermediate risk, and if they're high risk, a lot of times they'll say refer to cardiology. And that's all dependent on the patient level characteristics, the treatment that they had and how far out or if they're during treatment. But yeah, to answer your question, yes, the ESC guidelines have quite a bit within there in terms of giving someone guidance or when to refer to cardiology.
Right. I think we have time probably for one more question. I have a question. So as you pointed out with the current guidelines, there's even though there's a lot of classroom recommendations, a lot of the level of evidence is limited. So I'm curious, as more and more cardio-oncology programs pop up, both at academic centers as well as the community, how do we measure quality or assure quality for these centers? There's a lot of initiatives to try to develop, for example, either quality metrics, and there's even some talk about performance metrics. But I think the data is somewhat limited. So I'm curious what you think in terms of how we can measure quality of these programs.
Yeah, I think it comes down to is we have to have good evidence first within in order to have metrics, we have to understand what our metrics should be. And I think that'll be guided by further research into what is the most appropriate treatment, surveillance and things like that. Because I think at the current state with these guidelines, I think it's hard to tie performance measures to relatively low quality of evidence. I think that would be unfair to hold anyone to these levels where we really didn't know what's the best strategy. So I think in the future, once we know more and can make future iterations, then I think we can start thinking about, okay, this is the benchmark, for a center.
That sounds great. Great. So we're at 8:26. Well, thank you everyone for attending. That was like a fabulous talk, and we're excited to continue working with you.
Thank you.